Hi, everyone. It's me, Dr. Naveen Pemmaraju, professor of leukemia at the MD Anderson Cancer Center in Houston, Texas. I serve also as the executive director for the MD Anderson Cancer Network and the inaugural director for our BPDCN Blastic Plasmacytoid Dendritic Cell Neoplasm program here in Houston. And it's my honor to join Dr. Neil Love and the team, someone who I followed for over 15 years and has been integral in my hematology oncology education as I've gone through the ranks. So team, as a way of introduction, this BPDCN ultra rare disease field is something that I've had the privilege to be one of the world leaders in. And in fact, based on our work and publications in high impact journals, we've now created our first or inaugural center for BPDCN at MD Anderson, for which I serve as the first director. And we've been able to get grant funding, philanthropy, and other high-level awards based on this work. And so I want to share with you at the practical level what we've been doing in BPDCN and why it matters to your practices in 2023 and beyond. So Blastic Plasmacytoid Dendritic Cell Neoplasm, BPDCN, a long, unwieldy name that has really changed names half a dozen times over the past 30 years. Ultimately, this is a bone marrow stem cell disease, a blood cancer, which can affect four major compartments, making it very unique in our myeloid malignancy space. Number one, in the clinic, most of these patients will have skin or cutaneous lesions, already marking it as unique. And then to underline the hybrid nature of this rare, unique entity, bone marrow disease, followed by lymph node, and an unfortunately high rate of central nervous system involvement, which we will talk all about. So it's a protein disease, a shape-shifting disease, one that doesn't fit neatly into AML or ALL or skin cancers. It's a rare disease, maybe only 500 to 1,000 Americans a year diagnosed. And because of the rarity, the complexity, and the life-threatening nature, this disease requires our attention and medical research. Outside of these four major compartments, we've diagnosed patients in all other sites of the body, so frequent extramedullary presentation. And while there's no recurrent cytogenetic hallmark, as in other leukemias and blood cancers, there is one important hallmark that's present in 100% of our patients. And that's called CD123, or IL-3 receptor alpha, which is a surface marker present on 100% of BPDCN cells. By itself, it's not completely diagnostic, but the triad of CD123, CD4, and CD56 positive, or as we say, think 1, 2, 3, 4, 5, 6, really helps you to nail down the diagnosis. And when differentiating this entity from other more common entities, the more specific markers of TCL1, TCF4, and CD303 lead you to approximately 100% sensitivity and specificity. Now, although it's a hybrid disease in the clinic with skin, lymph node, bone marrow, and other presentations, remarkably, the mutational profile is almost essentially myeloid, and it looks like MDS, CMML, AML. By far, the most common molecular mutation in BPDCN is TET2, followed by ASXL1 RAS, splicing factor mutations such as ZRSR2, and even TP53 mutations. So those should all look familiar to you, as they are common in the myeloid malignancies. Finally, the reason why this matters is that this entity has had such a poor outcome, usually 1 to 1.5 years overall survival, despite modern therapies. And so after all, BPDCN is a visual disease. It is one that involves the skin in the vast majority of patients, either at diagnosis or subsequently later on in their course. The skin lesions from all over the world are shown here. Some range as maculopapular. Usually they are dark colored. Purple colored is usually one of the hallmarks of our disease, and can range, as you see here, from spots on the skin all the way to plaques or large tumor masses. And so as we think about BPDCN and its journey, especially this name and its classification, boy, it has changed quite a few times. You can see the graphic here. In 2001, it was known as blastic NK cell lymphoma, so some of our hematologist oncologists know it as this entity because of the CD56 expression. It was thought to be an NK cell-derived tumor. Obviously, that was proven to be not correct later on. Then called CD4 positive, 56 positive tumor, again, because of the markers I told you. Then in 2008, the WHO classified it under AML and related family of neoplasms. 2016, again, reclassified sort of as its own myeloid malignancy. And then yet again in 2022, the latest WHO 5th edition now places BPDCN under the category of hematolymphoid tumors, myeloid histiocytic dendritic neoplasms, with its own category under PDC neoplasm, so differentiating it from mature proliferation and then the BPDCN entity. And so in a rare disease, what actually is important is that sometimes these diseases are not as rare as we think. Obviously, a complex disease, name changes, it's not easy to diagnose it and differentiate it from other entities. We think it's approximately 500 to 1,000 Americans a year. We really believe that we're seeing many more cases now as we have drugs approved in the space and being tested actively, and we have a pathology and dermatology workflow. But approximately, when we've done SEER and other database studies, it is ultimately very rare, 0.04 cases per 100,000 in our own SEER database study, and less than 1% of all hematologic malignancies. And it remains an important entity in that the therapy appears to be different, the clinical course appears to be different, and so it's important to differentiate it from other more common entities. Most commonly, the differential diagnosis for the community hematologist oncologist includes AML with leukemia cutis. So biopsy is always important in these skin-related issues. Cutaneous T-cell lymphoma, obviously two separate categories of diseases, and yet they do get mimicked and mistaken for each other. Even other entities such as CMML, chronic myelomonocytic leukemia, which can have a paraneoplastic or other skin infiltrate, which can have PDCs, but they might be more mature and they're not quite the BPDCN. And then there are overlap entities with AML, such as the PDC-like AML, et cetera. I think the key, as in all of these areas, is just as we always do the bone marrow or lymph node biopsy in our leukemias and lymphomas, let's add the skin biopsy when we're considering these rare skin-related blood and bone marrow cancers. And so we convened the North American Blastic Plasmacytoid Dendritic Cell Neoplasm BPDCN Consortium, led by myself and Professor Kantarjian here at MD Anderson. And we were able to publish these results in Blood very recently. And basically, we got together all the experts in North America, US, Mexico, and Canada, pediatricians, stem cell transplant, derm, pathology, leukemia, everybody who's involved with BPDCN. And we put together these diagnostic criteria representing and reflecting the four major compartments of the disease. Because almost all patients will have skin involvement, we recommend expert referral with a dermatologist and biopsy of any visible skin lesions. We use the MSWAT scoring borrowed from cutaneous T-cell lymphoma to make subjective objective. We do recommend imaging at baseline in all patients. I go for a PET-CT scan if available. If not, then CAT scans, as you would in a new lymphoma patient. Bone marrow aspirate biopsy and blood work essential and crucial, sending off for flow cytometry, cytogenetics, and molecular, looking for the markers I mentioned earlier. And then finally, a lumbar puncture in all patients, an LP, to look for and to deliver chemotherapy. So look for disease, deliver intrathecal chemotherapy. I recommend up to 8 per patient. Why does this matter? Why does it matter that we focus on a rare disease together? That's because identification of this could be life-saving. Historically, as you can see from some of the largest series, patients with BPDCN do poorly. Usually the median age is 70, older, frail, sick patients. Given either AML-based or lymphoma or ALL-based chemotherapies, historically, the overall survival has been poor, less than a year. High death rates, including sepsis, infection, multi-organ failure, up to 26 to 30%, and really just suboptimal results. So as we say in our fields, truly, 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 this is an unmet medical need area, and that's why I dedicated my life and career to this. When we started to look for new targets together because we were having suboptimal outcomes. And as you can see here, a schematic of the BPDCN cell, the one that jumps out to you is in fact the CD123 or IL-3 receptor alpha. And so that's where we've directed the majority of our first efforts. And I'll show you a little bit of progress in some of the more intracellular targets, including BCL2. And so the quest began for a new therapy approach. We looked at the CD123 around the world. The IL-3 receptor alpha is simply fascinating. It's the transmembrane alpha chain of the IL-3 receptor. It is expressed at high levels on these PDCs, but also on monocytes, eosinophils, basophils throughout the lymphoid and myeloid systems. What happens is it binds IL-3 and then heterodimerizes with the common beta subunit. And basically what you're talking about here is this is governing apoptosis, proliferation, cell growth in these myeloid and lymphoid cells. And so if we can target this, we may be able to abrogate the malignant cell growth. The key is that 100% of our patients with BPDCN will have the CD123, but as the chart on the right shows, actually, when you really test CD123 in your labs, quite a few diseases will have it, including lymphoid malignancies. Okay, so we've identified a target, CD123, 100% of the time on BPDCN. Now let's go to the lab. Led by our colleague, Dr. Art Frankel, a molecule was developed and discovered known as DT-IL3, in which he took the truncated diphtheria toxin payload, fused it to human recombinant IL-3, and created this new molecule, ultimately known as SL401 TAG or Tagraxofusp. This targeted agent was meant to bind to the IL-3 receptor alpha, the CD123, on the surface of malignant cells, lead to internalization of the toxin, leading to irreversible protein synthesis and death of the cancer cells. In vitro and in vivo models, for BPDCN specifically, for the very first time, not derived from AML and MDS, showed that this drug was highly potent against BPDCN cells in the lab, and therefore we tested this in a pilot study first in humans. This study, now over 10 years ago, featured a total of 11 patients, 9 of whom were evaluable, receiving all the doses of one cycle of drug, and almost all of the patients responded, 78%, 7 out of 9, including the majority complete remissions. At that time, it was just a single cycle of the drug available, and there was a toxicity called VLS, vascular leak syndrome, also known as capillary leak syndrome, which was noted in these patients.
Just curious, it kind of sounds like you're describing an antibody drug conjugate, but you didn't call it that.
That's correct. It is in fact an early version of an ADC. That's absolutely correct, Dr. Love. Mm-hmm.
But it's not. In what way is it not an ADC?
I think you're right. I think when I think of these things, it's a bacterial construct, so it is an ADC. But what's juicy and interesting for us is this is one of those bacterial ones. And then when I show the IMGN later, it's more of a pure ADC that you and I are used to with a linker and a toxin. Right. Yeah. So I think that's why I think of this as different.
Right. Please continue.
Oh, good. Great. And so based on this pilot work that I published with Dr. Frankel in Blood now 10 years ago, that was a pilot phase 1 concept study. And this led to the very first prospective multi-cycle, multi-site, multi-center study with this agent, now with this name, Tagraxofusp. And now we commence with this study. So here, this was actually 4 stages in one. I show you the first 3 here. The stage 1 with the TAG agent was BPDCN patients, both frontline and relapse refractory, because there's no standard of care yet in our field. And the drug was given at the doses seen here, 7, 9, up to 12 microgram per kilogram, which is where we ended up stopping. And then in that stage 1, it was conducted as a 3+3 safety design. We found the drug to be extremely efficacious, but there was also 1 death from capillary leak syndrome. And so we were able to go back and revise our criteria, finding that the albumin level, the protein level in the body, correlated with that. And so we increased the albumin level, made sure that patients had normal cardiopulmonary reserve. The trial continued into a stage 2 expansion phase. Again, both frontline and relapse patients at the identified 12 microgram per kilogram dosing. It's an IV drug given up to 5 days per 21 to 28 day cycle. Hospitalization required in the first cycle. Here we also showed major efficacy in the vast majority of patients. And then we proceeded into a stage 3 pivotal or confirmatory phase, which is now only focusing on frontline patients with BPDCN, again at this 12 microgram per kilogram dosing. And before I show you the results and what happened, the important thing here is the inclusion criteria. Most people gloss over this, not so for us. Here, as I mentioned to you, we really made sure with the capillary leak syndrome finding that patients had to have adequate albumin, adequate creatinine, liver, and a cardiopulmonary reserve. And what happened at that point is we needed a response criterion. And so in this rare disease that did not yet exist, most people were just using AML or lymphoma criteria. And so we put together this, which has been favorably received by our field. Because it affects the 3 major compartments, skin, bone marrow, and lymph nodes, we use the MSWAT from cutaneous T-cell lymphoma, AML criteria for the bone marrow, and lymphoma criteria for the imaging. And as you might expect, a CR means that you have to have resolution of all of these compartments of disease that were there at baseline. Now, the safety profile showed that approximately 18 to 20% of patients will have capillary leak syndrome, a potentially life-threatening event, and the recognition of the capillary leak syndrome is paramount to understanding this brand new drug. Shown here, the schematic to remind you the capillary leak syndrome can be a constellation of tachycardia, hypo or hypertension, fevers, and a volume leak syndrome that is a different physiology than sepsis or simply fluid overload. The albumin levels being low or dropping is usually your biggest risk factor, so replacement of albumin, diuresis in the volume overload setting, high-dose steroids, early transfer to the ICU, early pressors is life-saving. We had many patients who can experience this, but then also can be safely salvaged, managed, re-exposed with the TAG agent, and can do very well, as this appears to be only a first dose, first cycle exposure. The reason why the capillary leak syndrome was so important in these early trials with our new agent is because it could cause potentially life-threatening circumstances. One young patient, as shown here, developed myocardial edema in the setting of this capillary leak syndrome, a rare side effect. It was thought to be mimicking a cardiac amyloidosis picture, and actually all it was just fluid. So simple diuresis, steroids resolved it. The patient was able to be re-challenged with the TAG drug and was able to go on to multiple cycles of TAG, including an allo stem cell transplant, is alive and well 3.5 years later. And this case has been published to show that sometimes these life-threatening toxicities are one-time first dose exposure and can be easily mitigated. So what happened with this drug, TAG, Tagraxofusp, SL401? Ultimately, we were able to conduct the trial, and we were able to enroll 47 patients, the majority of whom were frontline patients. In the frontline setting, this agent, CD123 diphtheria toxin-based agent, led to overall response rate in almost all patients. So 90% response in the frontline setting, of which 72% were complete remissions, and a respectable 67% in relapse refractory patients. I mentioned to you the major toxicity of capillary leak syndrome. In addition, approximately 40 to 50% will have thrombocytopenia and or LFT abnormalities, usually restricted to the first cycle. Really no neutropenic fever with this agent, no hair loss, well tolerated in older patients as long as you're managing and watching the fluid profile. Remarkably, to our delight and surprise, we were able to lead this drug to FDA approval, December of 2018, published in New England Journal by April of 2019. Not only it represented the first drug approved in our field for BPDCN, but also the first CD123 approved drug, which led now to an explosion of this field. And it also gained pediatric approval, ages 2 and older, as a separate case series, compassionate use basis, showed efficacy of the drug in younger patients. So this is an example, as I mentioned, it's a visual disease with the skin findings. One of our patients, 71-year-old patient, who presented ill with BPDCN, skin, bone marrow, other involvement. After the first dose of the Tagraxofusp TAG agent, complete resolution of these skin lesions, and also the bone marrow blast. This patient actually is 71 years old, not someone you would necessarily think of for cytotoxic chemo and transplant, was able to get the TAG agent 6 cycles and successfully went to an allo stem cell transplant. The second step was to try to gain European approval with this novel new agent. And again, the European agencies noted the capillary leak syndrome, 18%, including potentially life-threatening, but also manageable and potentially has mitigation strategies. And so it gained approval in Europe, a bit more limited basis, which is frontline adults only in January of 2021. And in the US FDA approval, I should mention, it did gain appropriately the so-called black box US FDA warning for the capillary leak syndrome. Now, what about long-term benefits of this novel drug in our emerging field? We were able to publish these results in the JCO recently, showing now with 3 years median follow-up, there's still a tail to the curve, median overall survival approximately 16 months. The overall response rate maintains at 75%, no new safety signals, no new issues with this drug. Here you'll see the number, now there's a stage 4 included. So the New England Journal reported the first 3 stages. Here we have long-term follow-up for the extension phase or compassion use phase. So 65 patients treated frontline with TAG, and that's the results you're seeing here. So very reassuring for us in the field to note that monotherapy, approximately half the patients were able to go to transplant. There is some durability, but there's still some work to go and some room for improvement. And as I mentioned to you, out of these 65 total frontline patients now, stages 1 through 4 in the original study, the overall response rate maintained at 75%. The CR/CRc rate dropped a bit to 57% in this long-term setting, 32% bridge to stem cell transplant, with the median overall survivals as shown there. And so for this first part of the talk, the summary and conclusion is that we now have a field with its first approved drug, and this Tagraxofusp SL401 agent has high response rates. We do note the capillary leak syndrome incidence, mitigation measures, and what to do about it. Patients are bridged to stem cell transplant at a high rate, so that is part of the journey of the BPDCN patient, as in AML or other life-threatening entities. And interestingly and amazingly, this agent and the CD123 field now is exploding, and so it's available and being investigated in a host of other disease sites, such as AML in combination therapy, myelofibrosis, CMML, even multiple myeloma. But the good news is we didn't stop there. We kept moving beyond the TAG SL401 agent, and now a second drug is in active clinical trial development. And that drug is known as IMGN 632, or pivekimab sunirine. This is a novel second-generation CD123 ADC antibody drug conjugate. And first, we investigated this in patients in the relapse refractory setting. So as I mentioned to you, very aggressive disease. Once it gets to the relapse refractory setting, including an overall survival of less than 1 year in these patients. So in the relapse refractory setting, first 29 patients, overall response rate is shown here, 29%. Importantly, in patients with the prior Tagraxofusp TAG treatment, 31% in this heavily pretreated high-risk group of patients, and really almost all patients receiving the drug having some form of bone marrow reduction, including complete remissions in this otherwise difficult setting. And so that led us to investigate the drug in the frontline setting. These results for the IMGN 632 pivekimab sunirine are shown here, hot off the presses, presented by me at the EHA meeting in Frankfurt, Germany, just this past June. And so as I mentioned to you, with the pivekimab sunirine, still targeting the CD123, but in a different manner, if you will, than the TAG SL401 agent, in that this ADC has its own novel linker and its own novel payload, the so-called IGN payload, which leads to DNA alkylating, and it causes single-strand breaks without cross-linking. And so this is designed to have a high potency against CD123, BPDCN cells, and also AML and other entities that can express the CD123. For our BPDCN study, as you can see here, we set out to do an international study for this one. So this included sites in USA and Europe, the so-called Cadenza study, open-label multi-center phase 2. Here we included the relapse refractory and frontline. I've already shown you the data on relapse refractory. I'm going to show you the frontline here. Interesting drug. It's only 0.045 mg per kg monotherapy IV. Can be given as outpatient even starting in cycle 1. It's a 21-day or 3-week cycle, a quick outpatient infusion. And with the understanding that BPDCN does involve the CNS at a high rate, we're starting to give intrathecal chemotherapy prophylaxis to all patients with BPDCN. So how did we do with this novel agent? So far, a total of 79 patients treated. I'll focus on the frontline patients as shown here. That's 30 patients. Median age of 74 up to 84, so reflecting a real-world BPDCN population, which is usually older, frail, unfit for standard chemo. Majority of patients over age 65. Most of the patients in BPDCN are male. That's a historical fact. Probably there's multiple reasons, one of which is that some of the splicing factors, such as ZRSR2, are on the X chromosome, and so that leads to X chromosome abnormalities. In the prior treated therapy group, 49 patients, you will note that this is a heavily pretreated group of patients, with half of them receiving either prior TAG, prior intensive chemotherapy, and remarkably, a third of the patients enrolled prior stem cell transplant. So a really, really true heavily pretreated group of patients that got onto the IMGN study. So let's see how we're doing on here. Safety first, out of all 79 patients included. A very, very safe and well-tolerated drug. 0 incidence of capillary leak syndrome. The most common was almost 50% of patients having a peripheral edema, so it can be seen in the upper or lower extremities, but not a central edema. A quarter of the patients do develop thrombocytopenia, usually restricted the first cycle or 2. And then a quarter of the patients can develop an infusion-related reaction, which was easily managed with dexamethasone pre-med steroids. Less frequent but notable, wanted to include, a lot of times ADCs can affect the liver, either through the linker or the payload. So there were a couple of patients who had liver-related AEs, as I show you here, including one patient notably who had what we thought was a VOD. Amazingly, that patient was able to do well and went on to a stem cell transplant. There was no capillary leak syndrome events, as I mentioned, and 0% mortality rate in the first 30 days in the frontline treated cohort, very notably. And so the data is shown here and is presented publicly now. very outstanding response rate in the frontline setting, 80%, so almost all patients responding with a composite CR rate of 73%. And notably, the time to response is quite quick, within just 1 to 2 cycles in the vast majority of patients. Also, remarkably, I showed you the median age in the 70s. 9 patients, so a third of the frontline patients, were able to be bridged to an allo stem cell transplant. Again, these are patients who were felt to not be fit at the beginning of the trial. How about duration response in these frontline patients? Now we've crossed median duration response of over a year, very outstanding in this group of patients with BPDCN, with a median duration of CR of 10.3 months. Well, we know the skin lesions can clear. What about the bone marrow blasts? Remarkable, again, with this drug, as we saw with TAG, all patients with bone marrow involvement had a response, including 11 out of 13 achieving an actual protocol-defined overall response rate. And so the conclusion from the INGM 632 is that we have a second active drug in process, and that trial is being accrued and matured, and we hope to see upcoming results. Other ways to target CD123 are in the more infant early stages. That includes going for CAR T, which many of you know from the lymphoma and other fields with CD19 and other more defined targets. In our BPDCN, AML, and myeloid malignancies, CD123, as we've noted here in this talk, appears to be a target of interest, and so we've designed the first CAR T trials, really still marked by early toxicity in BPDCN, and so no major clinical results yet to share, except there are both auto and allogeneic CAR T constructs that are being designed around the world, and so now entering the phase 1 clinical trials. Moving beyond CD123, importantly, is the finding of BCL2, which we all know in the both myeloid and lymphoid malignancy spaces, and has now been approved in both CLL and AML in combination. But importantly, even in our emerging rare disease area of BPDCN, our group and the Dana-Farber group in combination have found that, importantly, BPDCN is highly dependent on BCL2, maybe even more than AML, and that obviously targeting of it through the oral BCL2 antagonist, venetoclax, which we tested in the first 2 patients, yielded a benefit, although transient, as a monotherapy. And we published these results in Cancer Discovery. So this led us to then go for combinations with the venetoclax, as we've done in other disease types. This area was venetoclax with the hyper-CVAD ALL-based regimen, and the first 3 patients we treated all had responses and all were able to proceed to transplant, which allowed us to open at our site at MD Anderson a combination study of all 3 of these things I've shown you. So CD123, hyper-CVAD, and Ven for fit patients. The vast majority of our patients, though, are older, unfit, median age of 70. Many have other comorbidities, and so chemo, CD123 drugs may not be available to a lot of these patients. And so we put together with our Mayo Clinic colleagues, Professor Teferi and Dr. Gunga, to see if we could have more of a real-world assessment of BPDCN. And in the real world, a lot of folks, including myself, use HMA-VEN for these unfit patients. We took the first 10 patients in consecutive series between our 2 groups, off protocol, standard of care, comorbidities, unfit. Again, almost all 10 of these patients had some form of response in this standard of care setting, although most of them were transient. But 2 patients were able to be bridged to a potentially curative therapy with allotransplant, as they had reduction of the skin and or bone marrow lesions. So what do we do with this second piece of information, HMA-VEN? Well, it's already been approved in older AML, and so now we're testing that formally in BPDCN. And so we've already gone through some of the singlets and doublets, as I've shown you, and now we're to the triplet therapy, which is TAG plus AZA-VEN. So as a triplet in older, unfit patients, either relapsed refractory or frontline BPDCN, now open and enrolling at our sites, MD Anderson, Dana-Farber, and City of Hope. Well, let's not forget about chemotherapy. With all of the excitement, appropriate excitement, of the CD123 and BCL2 targeted therapies, we found 2 distressing signals. One is that patients are still relapsing despite getting smart monotherapy targeted therapies, and 2, many patients are relapsing with CNS disease. So what will we do about that in this important area for our field? Well, one is remembering that ALL-based therapy was around before these targeted therapies, and it seemed to work in a lot of these patients. There's a lot of reasons why ALL-based therapy may work in this hybrid disease, and I put some of them here. There is Ikaros inactivation in BPDCN, TDT positivity. There are case reports from around the world, vinca alkaloids and dex steroids alone resulting in chemo and steroid sensitivity to BPDCN. And then, of course, there is the CNS penetration that you get out of ALL chemotherapy. Furthermore, the CNS signal is much more dramatic than we appreciated in the pre-CD123 era. Now that we moved to CD123 and BCL2 targeting agents, we found that 20 to 30% of patients with BPDCN will have CSF positive, either at frontline or later on in the course, and this can be easily detected and maybe even mitigated by doing a lumbar puncture to send the fluid to the lab and delivering intrathecal chemo. Based on this, we found that patients with a higher burden of disease will be more likely to have CNS involvement. That makes sense. And so around the world, as we've published, we've now changed the practice. 8 intrathecal chemos for all patients with BPDCN, whether frontline or relapse refractory, following a high-risk ALL model, and this has greatly changed and assisted our practice. As we think about the ALL-based regimens, the one that's worked the most is the hyper-CVAD regimen, although to give it at full doses, one needs to be a bit younger and fit and have blood transfusion and infection support. You can adjust it for the older patients using either mini CVD or dose adjusted. And so based on all of this, as I mentioned to you, we're trying to form these total, triple curative therapies for BPDCN, potentially in the model, if you will, as multiple myeloma or AML, which has moved to triplets and quadruplets frontline rather than awaiting relapse with its dreaded outcomes. And so this is one schema, as I was mentioning to you, using the TAG agent with the VEN and the hyper-CVAD in alternating doublets to obviously respect and watch for toxicity, and either go to an allotransplant or potentially maybe even one day eliminate the allotransplant completely, as many of these patients are older. So far, the allotransplant appears to be curative for many younger, fit patients. The median age, though, is 39 in our own series, as I'm showing you here. So roughly half the age of the normal real-world patients. So younger and fit, for sure, allotransplant. Even in the older patients I'm showing you, we're improving the performance status. So consider the allotransplant for everyone in CR1. Yes, we are doing auto transplant in limited cases of BPDCN, although we don't understand when and how to deploy the auto stem cell transplant. So as we've made progress in the CD123 field, these drugs are now moving into other fields such as multiple myeloma, CMML, MDS, AML, and other areas, including post-transplant maintenance. So please, let's all join together to see how the CD123 field goes. So in conclusion, I would say that this emerging area of BPDCN, which was fairly unknown 15 to 20 years ago, I'm happy to tell you we've made monumental progress in our field. Now in the front line, as you can see, you have multiple options for standard of care, either the CD123 approach, either on clinical trial or the TAG agent, FDA-approved. Historically, we know that the ALL-based regimens work, so either hyper-CVAD or I like to add in the venetoclax there. And then if you're older, unfit, perhaps HMA-VEN approach. And for all patients with BPDCN, please, please, please remember to add CNS therapy. For the future, of course, these triplets, CD123, BCL2 chemotherapy, let's try to think about putting all of these active agents thoughtfully so that we can once and for all eradicate and cure BPDCN in the frontline setting. And then in the relapse refractory setting, this remains an urgent area of unmet medical need. Outcomes are poor here, as I mentioned, survival less than 1 year, lower response rates. So can we develop the CAR T and other immunotherapies and combinations in that setting? As I think about future directions in our field of BPDCN, it's really wide open now. We've really asked a lot of questions, and there's a lot of excitement and momentum. One of these areas I show you here. There is the postulation of an in-between entity, maybe 3 to 5% of AML cases that have BPDCN-like or PDC-like features. And this was published out of the lab of Ross Levine from Sloan Kettering a few years ago. The concept is that you can have AML, but you have BPDCN features, and they wanted to investigate these patients further. Surprisingly, remarkably, 3/4 of these patients were shown to have RUNX1 mutation. That was a completely new finding, as you don't see this normally in BPDCN. They did have increased skin lesions, and in the lab, these patients seemed to benefit from the CD123 targeting. And so the question will be, can we further define this PDC AML entity? Can we separate it out from both BPDCN and AML? So based on this, I was asked to write the editorial, and I asked the question here to you, our audience, which is based on this: is targeting the PDC easy as CD123? Of course, the answer is not quite, but we're making progress. So possibly the future will be combination therapies with the CD123 in both BPDCN and in AML. As we think beyond CD123, BCL2, and chemotherapy, greater pathobiological understanding of BPDCN is really required. And I'm happy to tell you we're partnering with scientists from around the world to answer 3 or 4 key questions that I'd like to show you here. One is that, as I mentioned to you, it's a little bit interesting that TET2 is by far the most common mutation or abnormality in BPDCN. You'll see it even in patients with skin-only disease, even if the bone marrow is clear. This suggests either a CHIP, clonal hematopoiesis of indeterminate potential, or other origin for BPDCN. So we asked the question in our lab group, is the type of TET2 mutation, does it matter in BPDCN? And we did find that it did. We published these results recently that truncating mutations appear to be worse overall survival in BPDCN as compared to missense. And again, I showed you that potentially patients with these TET2 and other mutations have more incidence of CHIP, CNS disease, so we need to further understand what the significance of TET2 and BPDCN is. We further asked the question, are there differences between BPDCN and TET2 mutated AML? And we found to our surprise that BPDCN is a much more cytokine-rich state. We published that eotaxin and rantes, these are eosinophil chemoattractants, are much higher in BPDCN than TET2 mutated AML. And in fact, this may also help us to understand why BPDCN is so chemo and steroid sensitive at baseline. What about this male predominance I mentioned to you? Our Dana-Farber colleagues, in collaboration with our group in Sloan Kettering, made the discovery that the ZRSR2, which is present on the X chromosome, may lead to some of the male-biased results of BPDCN. It's 80 to 20, so it's a 5-to-1 ratio. And the ZRSR2 splicing mutation, which we see in MDS-CMML, here leads to impaired PDCs. So impaired plasmacytoid dendritic cell activation, apoptosis, may be contributing to the pathogenesis of BPDCN overall. Also, latest findings show that potentially UV light is helping to lead to the damage and shaping dendritic cell leukemia transformation in the skin. Interestingly, this is most potent in TET2 abnormal cells, and a lot of these lesions in BPDCN are in skin, sun-exposed areas, therefore starting to develop the first time a story here for BPDCN. I think one of the last issues to really mention to our audience is that even though it's a rare disease, now that I've seen so many of them and they come to us from all over the world, we've now published and noted that up to 20-25% of these patients will have PCHM. That's prior or concomitant hematologic malignancy. This is rather shocking. So in a rare disease, for a fifth to a quarter of the patients will have either an MDS or CMML most commonly, or an MPN, or a myeloma, or a TALL, either with the diagnosis of BPDCN or before it. That's a remarkable finding, and it's not something we expected. So theories, of course, again, we know that most of these patients are older. Is there a chip basis to it? Is there a clonal basis to it? It's interesting that you have the TET2 as common here. It's also common in CMML, MDS. So a lot of research is being done in this unique area. And then finally, we're hearing from all over the world. Now that we have a field, I get calls twice a week, 2 to 3 times a week, about cases of BPDCN from all over the world. More and more now pediatric and AYA patients. It used to be thought to be almost exclusively a disease of older adults and very, very rare entity in pediatric. But I can tell you we're getting a lot of calls about this. And this is one case, one case from Lebanon, actually, our colleagues, that we helped to advise on, which was a relapsed refractory patient, 10, 11 years old. After a transplant, we were able to deliver the hyper-CVAD venetoclax in the setting of extramedullary involvement of BPDCN in this young patient, who was able to go to transplant a second time and is alive and well. And finally, I think, Dr. Love, events like this are super important for our field to raise the awareness. Medical education, social media, online, and other resources. I myself benefited from learning and hearing from your CDs and DVDs a decade and a half ago. And now with the new forms of media, including social media, Twitter, LinkedIn, and others, we're able to get the message out, and we do get referrals directly from these sources. And so it reminds me to say that even if you have a rare disease, it's not rare to you. It's not rare to your family, your parents, your spouse, your caregiver. It's a disease. It's something you're battling. So whether it's 500 patients or 500,000, I'm glad to know that we can reach and connect with people all around the world who care about the same disease. And to that end, we formed multiple consortia, including the North American one I mentioned earlier. We now are working with Dr. Gavorag Tamamian in Armenia, and we formed an international BPDCN international registry. and then with our AYA and pediatric colleagues at MD Anderson and around the world to develop a consortia for those patients so that every single patient and case we're able to collaborate on best practices, research samples, and move our field forward. And with that, I'd like to conclude by thanking all of my team members, both at MD Anderson and around the world, our funding partners, and to just say, let's keep going. We've got the momentum. Let's keep working together. Thank you so much.